Welcome to Living Irving, the space where we talk all things beauty, self-care, healing, and confidence for mature women. I am honored to introduce a very special guest, someone whose expertise has helped thousands of women reclaim their bodies, confidence, and peace of mind. Joining me today is the world-renowned pelvic surgeon, Dr. Lennox Hoyte, a true pioneer in urogynecologist and reconstructive pelvic surgery, and the director of the Pelvic Floor Institute of Florida. Now, Dr. Hoyte specializes in advanced mesh removal, pelvic floor repair, and restoring women's health and quality of life after traumatic pelvic procedures or long-term issues that often go undiagnosed. I am deeply grateful to have the opportunity to speak with him today and ask the questions so many women in our community need answered. So grab your notebook, settle in, and let's talk about healing, wholeness, and hope. And let's welcome Dr. Hoyte. I am honored to be interviewing you and honored to introduce you to my community. So many women are suffering from this that I found out. I have some friends that are dealing with this, and so I wanted to bring you on so that we can talk about these things and what's going on. So thank you so much for having me, and thank you so much for being here.
Well, I'm so sorry to interrupt, but thank you so much, Latanya, for having me on your program. I appreciate the opportunity to share my knowledge and understanding of pelvic organ prolapse, pelvic floor dysfunction, urinary incontinence, surgical complications, and any other things related to pelvic floor issues that women that see your program care to hear about.
Let me get my glasses on. I got so many questions to ask. Dr. Hoyte, I would like to ask you, so what exactly is the female pelvic floor, and why is it important to a woman's overall health?
Absolutely. So the pelvic floor loosely refers to a set of organs and tissues that basically help control reproductive function, bowel and bladder evacuation. So it's that part of a woman's body below the pubic bone where a lot of really vital organs are contained. The bladder, the vagina, the rectum and anus, the uterus, and the tubes and the ovaries. And these organs are supported and surrounded by a set of muscles and bones. The muscles themselves are actually what's called the pelvic floor. But when we refer to the pelvic floor, we usually are talking about the organs inside, namely the bladder, the bowel, and the vagina, and the uterus, tubes, and ovaries. So that, in a nutshell, if you will, is the pelvic floor.
What are the most common problems or disorders that can happen with the pelvic floor?
Well, I think for women in your age group, we're going to kind of focus on the kinds of things that tend to be associated with a certain age range, and usually the difficulties that occur with pelvic floor issues have to do with bowel evacuation, bladder leakage, urinary urgency frequency, and depending on various other background issues, bulging or falling out from the pelvic floor. So cocktail party conversation would be basically for a woman something falling out or bulging, something leaking, bowel or bladder, and pelvic pain, things that hurt. So those are the issues for the women, I think, in your audience, I think that are ranged in the premenopausal, postmenopausal age group. That would be it. For women that are much younger, issues like recurring yeast infections, UTIs, difficulty with pregnancy, difficulty conceiving, painful periods, and so forth, tend to go along with women that are in a much younger age group, I would say in the 18 to 35 range. But over 35, the pelvic floor issues are the ones that would affect them, the ones we discussed first.
You mentioned with the pelvic that things fall out.
Yeah.
So tell me a little bit about some of those things. Like, how do we know as women that something's falling out?
Sure. It's going to basically require a little bit of anatomy, so if you can bear with me for a little bit.
Okay.
If you look on the outside, if you go to the shower or the bathroom and you look with the mirror, you don't see very much. You see the lips, the labia, if you will, in between the thighs, and usually that's all you can see.
Okay.
If you sit down to urinate or empty your bladder, you'll see a stream of urine come out from that area. down there.
Okay.
If you try to have a bowel movement, you'll see bowel activity happening in that area as well. But in fact, what happens on the inside is a little bit different. So if you separate the labia, for example, what you're going to notice if you look closely is that there's a long tube called the vagina that goes all the way inside, and it's actually pulled up in the inside and held in place by ligaments, and it's actually zippered to the inside of the pelvic floor. I say zippered, I mean that loosely. And that tube, instead of being a tube, it flattens out. That tube now holds up the bladder. It keeps the bladder in place and helps the body hold on to urine in times when you don't want to urinate. The back part of the vagina also keeps the rectum in place and allows you to hold on to stool, bowel contents in times when you don't want to have a bowel movement, like now, for example. At the top of that vagina sits the uterus. It's actually plugged in like a cork in a bottle. It's plugged into the top of the vagina. And the uterus is actually connected to the tubes and ovaries a little bit higher up. And that whole complex is held in place by ligaments that keeps this vagina pulled up in place and the flat tube. Okay. When that happens, the bladder is held up nicely in place. The bowels are held nicely in place. And what you can see from the outside is just the labia. That's how it's supposed to be normally.
Okay.
Now, after childbirth, for example, a big 10 centimeter head coming down a very small vaginal channel, that can stretch the ligaments, it can stretch the vaginal tissues, and it can actually act to unzipper the vagina from the insides. Oh, wow. So when that starts happening, this long tube that was previously held in place and held high up, that tube starts to sag. And when that sagging happens, what you notice is that the vagina can actually fall and start bulging out. A lot of women will experience that as pelvic pressure. Okay. Low back pain that's worse at the end of the day. They might actually even see a bulge or something coming out of between the labia. So the labia, when you look, you might see something different than what you're used to seeing falling out. And that's usually the vagina. There's names that we give to it, like if the front part of the vagina is falling down, that's mostly bladder coming down, they'll call that a cystocele. If it's the back wall that's coming down, mostly it's called a rectocele. There's other names like enterocele and uterine prolapse, but really it's all the same thing. It's the vagina sliding down, and usually the risk factor for that is childbirth, heavy lifting, constant long-term constipation and straining. And when you have that problem, it's not just the bulge. Other things start happening. Urinary urgency, you have to go to the bathroom to urinate very often. The urine stream decreases. They feel like they're never finished urinating. You pee a little bit, you get up, you have to go back. You keep coming back and forth to urinate. You're never quite feeling completely empty. Urine leakage associated with coughing, laughing, sneezing, or even with urgency. Okay. There can also be difficulty emptying your bowels. Some women have to report having to maneuver themselves and position themselves on the toilet to help the bowel movement come out. Some women even talk about having to put their fingers in places to help push things out and so forth, which can be quite disconcerting for a woman, as you would expect. And so these problems can occur also associated with pelvic floor dysfunction, pelvic organ prolapse and such. Another thing that can happen with women is that the muscles that hold all this complex up can sometimes get so tight and tender that they hurt. So when you try to have intercourse, for example, you might experience pain in different kinds of ways. And so the muscles can misbehave. Other things that can happen, especially in the peri and postmenopausal region, and it's a more and more important topic these days, is menopause will dry the vaginal tissues out, which makes for worsening of those bulge sensation symptoms, the urinary urgency, frequency, recurring bladder infections, and so forth, can also worsen as a result of the lower estrogen levels that can happen in menopause. So there's a lot that can go wrong.
Wow, that's serious, and it's not something that I know of that I hear from women as we talk about issues amongst each other and what we're going through, but
most women don't talk about it because it really has been quite an embarrassing set of symptoms that I don't feel like you want to talk about that with your girlfriends. And many patients that come to our practice at the Pelvic Floor Institute here in Florida say that, I've had this problem for 18, 19, 20 years, and I was too scared to talk about it. And after I went and I talked to my parents about it, my mom or my auntie or whatever, she says, I've had that problem for years. Nobody talks about it because it's gross. Who wants to talk about leaking urine or poop, right? People don't want to talk about that. But the problem's there, it's real, and most importantly, it's fixable. and diagnosable and fixable with the right kind of pelvic floor specialist.
Yeah, I hear what you're saying about like embarrassment, but this sounds very serious, like something bulging or just having those types of issues. Wow.
So we refer to those in clinical space as quality of life issues.
Okay.
It's not a life and death matter like an appendicitis or a stroke or a blood clot or anything like that. It won't take your life immediately, but it'll mess up your quality of life sufficiently that you stop living life the way you want to live. So women talk about having to know where all the bathrooms are at all the malls.
Okay.
They don't go on long trips unless they knew where all the bathrooms were, for example.
Wow.
They have to buy and wear pads. They don't like the way that things smell because of leakage and so forth. So it's quite embarrassing, and women tend to, scale back their lifestyle because of that. And that's not something that they need to do. A lot of these problems are fixable, and you can actually get your life back with the right kind of diagnosis and treatment.
Wow. Now, I'm a mature woman, but how common is it, like what age group is this most common in? Do younger women, like someone that maybe in their 20s that are starting to have children, do they experience these type of things, or are we even aware? Like we just think maybe we're swollen, or are we even aware what's going on?
Sure. So the big risk factor for much of pelvic floor dysfunction, prolapse or the bulging, the urinary leakage, it is related to childbirth. The childbirth-related injury. So the risk factor for prolapse and incontinence, the big one is childbirth. The issue, because the pelvic floor is so complex, we're so fearfully and wonderfully made, God made us so well, is that there are multiple different systems that work to hold things in place and hold it up. So even though childbirth might present the first insult because of the big 10-centimeter head coming down the small channel, the zippering that I talked about, for example, that can hold the vagina up side to side, that actually requires a lifetime of running, jumping, lifting, squatting, straining, throwing golf balls, swinging golf clubs, throwing bowling balls, and so forth. Over time, things get worse progressively. So even though the childbirth happened in the 20s, the actual visualization and the seeing of the problem might not occur till the 40s or 50s. So most of the women that come to me come around the time after menopause, which is when it becomes more obvious. Now, some women say I've had this problem for 19, 20 years, but I had my kids and I had my take care of my husband and so forth, and now that all of those things are addressed, I can start looking out for me. Women are really good at taking care of everybody else except for themselves. So the risk factor is childbirth, which, as we agree, would happen in the 20s and the 30s, but the manifestation of the problem, the actual time when it shows up and becomes an issue for women, tends to be more the 30s, 40s, and 50s.
Wow,
especially around urinary leakage, prolapse, and so forth. Pelvic pain is different because pain with intimacy and so forth tends to happen in younger women more, but it also can happen in peri and postmenopausal women, often related to lowering estrogen levels that can change the dynamics of the vaginal tissues, for example.
Okay, so it sounds more annoying than painful, or like uncomfortable, so maybe women just don't know. It seems like.
Yeah, so I think many women know that they're leaking. I think it's hard to not be aware of the fact that you're leaking.
That's not
or
normal.
that you have urgency or frequency.
Okay.
But many women are led to believe that that's part of normal aging. So I gotta just live with it, honey.
Okay.
And they live with it, and the fact is that's not true. So that's the awareness that I think if you wanted to bring that to your viewers, the awareness that, no, get it evaluated. There's a way to manage it and treat it and look after it. There's non-surgical methods, there's medications, there's small surgeries, there's large surgeries, and we're gonna probably talk about this. I'm sure you'll ask me about how you fix some of these problems. Sometimes surgeries with synthetic meshes, which are falling out of favor, and then using your own tissue, the native tissue repairs. There's all kinds of ways that competent, capable, skilled practitioners can help you. And it goes all the way from doing nothing to physical therapy to medications to small surgeries to bigger surgeries. There's something in there for everyone. Most women can be fixed.
Wow, well, that's good to know. That's awesome. So this is not something that's life-threatening or tragic, and it is fixable for sure. Okay, that's good to know because it sounds so serious. So, Dr. Hoyte, what are the major risk factors factors that can weaken or damage the pelvic floor over time?
So the biggest risk factor that we know of, that we admit to, is vaginal childbirth. So if you push a baby's head this size down a channel that's this small, something's going to win. Usually the baby's head wins and comes out. Vaginal tissues will stretch in childbirth. Many times they'll come back together. They never come back together perfectly, so we're looking at somewhere in the 30 to 40% of women that have given birth vaginally will have some kind of residual pelvic floor dysfunction.
Okay.
Whether it's a disrupted muscle, or whether it's a vaginal prolapse or vaginal injury that's leading to prolapse or urinary incontinence, one of those things will probably happen to about 30, maybe 40% of women over time at some point following vaginal childbirth.
Wow.
Even women who have not given birth vaginally can be at risk for pelvic floor disorders. We don't understand that mechanism as well, but the fact that you've never given birth, never had a pregnancy, doesn't free you entirely of the risk of it. That risk is much smaller, but it's present. Some of us believe that that may be genetic in origin, that having to do with the types of collagen and so forth that genetically go along with that woman.
And that's what I was wondering, is it genetics? Because I was always told at a young age that we as women follow our mothers. And like if they started their cycle early, or if they had painful cycles and things like that, is this hereditary?
Yeah. So I think one of our colleagues years ago did a study on nuns who did not have pregnancies or give birth, and their sisters who had given birth, and they found some correlation in the genetics between women of similar genetics and the risk factors for prolapse. So,
Gotcha.
I think if your mom had it, then you definitely want to be asking questions and looking into it. But I think whether your mom had it or not, any woman should be looking seriously at symptoms of urinary urgency frequency, leaking urine, having to get up more than twice a night in order to urinate, difficult bowel evacuation, pelvic pressure. No woman should endure pain with sexual penetration or intercourse. That's absolutely unacceptable. It's unnecessary, and it's fixable. So all of those kinds of symptoms, pelvic floor symptoms as a general matter, should be investigated. Vaginal dryness, for example, in the perimenopausal period, goes along with decreased estrogen levels that happen during menopause. Every woman should be aware this is not normal. It ain't normal. And I think for women, especially women in the West, getting with the notion that, I don't have to live with that, is, I think, an important and liberating concept. And I think it's something that women need to be aware of. If you're having those kinds of symptoms, find someone who specializes in pelvic floor disorders, go have them evaluate you. And many times out of 10, the vast majority of times, you'll find an answer that you might find helpful.
So what type of, just listening to this and being a married woman, I could definitely see this being a problem and just so uncomfortable.
Sure.
Like, oh my goodness. So that is one of the major signs then, if you're having pain during intercourse.
During intercourse, sexual intimacy that's a problem can have a number of different components to it. One is the head components. I don't feel like it, I don't want to do it. That's usually, that kind of desire or libido usually goes along with falling hormone levels in the perimenopause.
Oh wow, so it lowers the libido.
So absolutely. In perimenopause will lower libido. There's a lot of things happening as we all get older, more life stresses and things like that, but changing hormonal milieu will definitely affect your libido, affect your brain fog level, affect your energy level, certainly will affect your muscle mass and just general well-being as well. If in the act of intercourse with a male partner during penetration you're feeling pain, that is not normal. It absolutely is not normal, and it should get looked at. Having a provider or a practitioner who can evaluate you, examine you, replicate the source of the pain. Once we can do that, we can start talking about ways to get it fixed. Usually it's pretty straightforward in a perimenopausal woman, not a surgical issue, especially if you had a life of normal intercourse activity and then things start hurting. That's pretty straightforward usually to get fixed. Sometimes it's more serious.
Wow.
But it can be addressed.
That can definitely be very stressful on a marriage, I can tell you that. So pregnancy, childbirth, menopause, obesity, health lifting, chronic coughing, which one are most common? And are some women genetically more at risk?
Sure. That's a really, really good question. It's a hard one. We do know that the big risk factor is vaginal childbirth.
Okay.
Other associated risk factors relate to things that make you chronically strain. So women with COPD that strain a lot, for example, will put pressure on the pelvic floor and worsen the risk profile. Women who have to strain at constipation for some reason or another, you're having a hard time and you got to really strain it stool chronically, that will create a risk factor as well. We've learned that women that do parachute jumping, where they fall out of a parachute and then suddenly hit the ground and decelerate suddenly, those tend to be higher risk factors as well. People that do a lot of heavy lifting, a lot of big time heavy, people that work on horse barns, for example, bales of hay weigh, I understand, in excess of 100 pounds. If you're throwing those around, those put pressure on the pelvic floor as well. Those are the big ones. Smaller risks tend to be around genetics, and those are less well understood. One of the common ones includes something called Ehlers-Danlos syndrome, which is a kind of collagen disorder where tissues tend to be more stretchy. Those women feel like they're at higher risk. Ehlers-Danlos syndrome is what it's called. So that's another one. Other kinds of collagen disorders can sometimes put you at risk. Those tend not to be the main ones if you look across the landscape. If you're a woman with Ehlers-Danlos, it's a big deal, obviously, but as a general matter, looking across your many tens of thousands of viewers, that probably is a lower percentage.
Wow.
For women.
Wow. Well, thank you so much for answering that. So, let's see here. How do everyday activities, habits, and lifestyle choices influence pelvic floor health?
Sure. So everyday activities. One of the things we say, and everyone agrees to this, that are in the pelvic floor cure issues, the vagina is like a self-cleaning oven. You do not need to wash it out.
Oh, wow.
Do not need to douche, do not use vinegar, do not use those things. The only things that should go into vaginas usually should be, sexual type of toys and men and body parts and so forth. Sometimes we prescribe a vaginal suppository or cream for the vagina that's usually estrogen or an estrogen-like product. Those can go in. Definitely don't douche.
Okay.
Putting things in the vagina changes the biochemistry of the vagina and puts you at higher risk for things like yeast infections and UTIs and things like that. So that we don't do. In terms of lifestyle, some women that may be at higher risk for, they're called honeymoon cystitis, they get UTIs after they have intercourse. Those women, sometimes it's very rare, but sometimes those women might need to be treated with an antibiotic that they might take after intercourse. That's not for everyone. That would be something that you go over with your doctor, right? When we talk about the kinds of underwear that you wear, for example, we like underwear that's breathable, cotton, more cotton, silk kinds of things, less synthetic materials that restrict airflow back and forth, because tissues need to breathe. Vaginas and pelvic floor tissues also need to breathe. The old classic that you learned from your mom, wipe from front to back after you have your urinate and so forth. Those are all great. And standard hygiene methods, keep the area clean, wash soap and water on the outside, is probably a good chunk of being helpful. Now, we like in our practice to make sure that most of our patients, the bulk of our patients, are on a good oral probiotic. Because managing the gut flora impacts the vaginal tissue, behavior and function. So getting a good gut flora is going to help the pelvic floor and help the vaginal tissues as well, like prevent UTIs and yeast infections and things like that. That's what you're looking for.
So during this question you mentioned, so these things, a lot of women, we use over-the-counter things like Summer's Eve, and some women use deodorant down there to keep odor down. Some women use powders and things like that. So what you're saying is the vagina does it's
a self-cleaning oven.
It's summertime.
It's self-cleaning. Keep the area aerated, cotton. I mean, if you're gonna obviously wear a swimsuit or whatever, you do it for the period that you're doing it, and then you're done. Wash soap and water, a regular, probably a scent-free soap.
Okay.
In the neighborhood. If you're worried about discharge or odor is not normal. There's a natural and normal odor that goes along with vaginal tissues that's not unpleasant by any means, right? If you're feeling like there's an unpleasant odor, you might want to have that looked at a little more closely to determine why that's happening. The odor from the vagina should never be unpleasant under normal circumstances. If it is, something's going on. And the kinds of things that could be going on could be injury related, it may be an issue related to bleeding, it may be an issue related to a sexual type infection that, God forbid, happens for one reason or another. And there's certain kinds of disorders related to the acidity of the vagina that can actually sometimes create an odorous situation. One of the conditions is called bacterial vaginosis. It can actually happen when the level in menopause, where the pH level of the acidity, if you will, of the vagina prevents certain kinds of good bacteria from growing.
Okay.
And that could lead to the bad bacteria causing odors, but that needs to be looked at and managed by a healthcare provider. Abnormal odors, not normal, shouldn't be tolerated. But you don't have to deodorize the area. You shouldn't have to.
So if you're experiencing this pressure or this bulge and things like this, and you are aware that you're having something going on, doing these type of things with the douching and things like that can worsen?
Douching is never helpful. Douching will change the pH of the vaginal tissues and put you at risk for weird kinds of infections and malfunctions of the pelvic organs.
Okay.
It just will. Douching is unacceptable.
Gotcha. Wow. All right, let's move on. Let's see here.
And there are things that are allowed to go into the vagina. The vagina is a two-way street. It was designed to be a two-way street. What comes out are babies, menses, and so forth. What goes in can be penises, safe toys, penises, toys, creams that are prescribed by a provider. Those are acceptable to be going in, but not over-the-counter stuff necessarily.
Okay.
They don't help, and they actually can harm.
Wow, thank you for answering that.
As a general matter.
That's helping me because I must admit, I do mine.
I get it. I understand the need to be DIY and do it yourself.
Yes.
Occasionally around areas like that, I would say having a good, competent practitioner involved and in the mix, working through with you why you have that odor or that discharge will probably go a longer way towards getting you fixed than trying to do it yourself. You stand a chance of making it worse. Skin creams, facial ointments, that kind of stuff, I'm okay. That's good.
Okay.
But getting on the inside of the vaginal tissues with things that haven't been vetted or carefully thought through, that's probably not a good idea. And that's not a do-it-yourself activity, I don't think.
Okay. Thank you for answering that. Okay, so are there signs or symptoms women often ignore that could signal pelvic floor problems?
Okay, so one of the things that women have told me in the past and continue to tell me in my practice is, I gotta stop every 10 minutes to go urinate.
Okay.
I thought I had UTI. I took some UTI. I drank some cranberry juice. It didn't help. They told me that's normal. It's part of normal aging. They live with it. Not normal. You don't have to live like that. Sometimes it's a bladder infection or a cystitis, but sometimes it's related to just the fact that you're in perimenopausal area and the vaginal estrogen levels have dropped, and that leads to urinary urgency frequency. That's called the genitourinary symptoms of menopause. Getting it fixed is as simple as replacing the estrogen in the vagina. Vaginal estrogen therapy will make that problem go away. If the urinary urgency frequency is happening because of prolapse, if the prolapse is diagnosed and properly repaired, either with non-invasive or surgical techniques, that can usually make the UTI symptoms go away. The key really is finding someone or a practitioner who's skilled, urogynecologist, female urologist, gynecologist skilled in pelvic floor dysfunction are the ones that you're looking for to see about getting help with understanding what's going wrong and what's fixed. Problems with bowel movements, constipation, having to strain at stool, having to put your fingers in splint, having to maneuver yourself to have bowel movements, also not normal. A lot of women will put up with that. It starts getting dicey when they're leaking stool because nobody wants that. So that might get them to the doctor or a practitioner sooner.
Wow.
Also, constipation can be an issue that sometimes they can ignore.
Wow.
Pain with intercourse. So they try to have intercourse with their male partner and it hurts. Some women might respond by just not having any more intercourse with the partner, and they might agree that, yeah, we shouldn't do that. I think by itself, just at least getting it evaluated would make sense to do, because that at least gives some insight into the why of the problem. So that they know what's going on, so that at least if something that's fixable, they can fix. Next layer up is things like energy level, brain fog, sexual desire, libido, those kinds of things. They start falling off. That's not normal.
Okay.
And I think there's a sense, and we're coming to more and more agreement, that sexual intimacy between committed partners is really an important part of normal life, and it actually helps to energize and make life better for both parties. And so when that starts falling off, the whole relationship dynamic starts changing when the intimacy goes away. So if you're feeling that that's a problem, I think it also makes sense to come and get that looked at by a practitioner that's expert in menopause care.
Wow. You mentioned urine, frequent urine a lot. So what is normal urine time frame? Let's just say if somebody's going to the restroom 5 times in an hour, is that
not normal?
That's not normal.
Usually about every 2 to 3 hours is considered normal.
Okay.
Once or twice at night, getting up from sleep once or twice at night, or none, is within the normal range. Once you push much past 1 to 2, then you got to start asking questions and having somebody look at why that's happening. That's called nocturia. Usually it's more than about 2 times a night. That's what we've listed as. But obviously this all depends on how much fluid you take in when you drink, and so forth. Some people take drugs, medications for hypertension that are water pills, for example, that can alter the dynamic. But usually I think in the 2 to 3 hour time frame while you're awake, and 1 to 2 times a night is considered normal. If you're much beyond that, in one way or another, I think you should have that at least looked at.
So does it feel like if you, sometimes, I've used the restroom and it feels like I have to use it again, but you go to the restroom and it's just like a little squirt? Is that?
Yeah, that sometimes can go along with either a bladder infection, so-called UTIs.
Okay.
Sometimes prolapse will do that.
Okay.
Tight pelvic floor muscles, if you find that that's associated with pelvic pain issues or pain with intercourse kinds of issues, sometimes the tightness of the pelvic floor muscles can actually squeeze the urethral muscle and make it hard for you to urinate. So that always also can be an issue. The other thing is that if you've had a kind of surgery that is supposed to tie up or tack up the bladder so you don't leak, sometimes that surgery can be overdone and the bladder now can't empty at all. So you have urinary retention, so the bladder pushes the urine out every 5 minutes and you're never feeling like you're empty. There's always a lot in there. And that can be a problem as well. That's why, in my opinion, once you start getting those kinds of pelvic floor, bladder, bowel pain symptoms, it really makes sense to go have it evaluated by a urogynecologist, female urologist, pelvic reconstructive surgeon, or gynecologist that specializes in pelvic floor disorders. That's what you really need to have done.
Yes.
And it's better to be pronounced healthy and sent off on your way than to have something wrong and not figured out. Because usually, if it's at that point in the game, usually it can be fixed quite straightforwardly.
Thank you. So Dr. Hoyte, how can women protect and strengthen their pelvic floor before problems occur?
Absolutely, that's a really good question. So as far as we can tell, there's some limited evidence that suggests that maybe getting pelvic floor physical therapy on the pelvic floor muscles to rehabilitate them before childbirth sometimes can be helpful. I don't know very many women that want to go ahead and do that, and I'm not sure what the exact number of rescued or saved pelvic floors would happen as a result of that. Usually we talk back in the obstetric days, if you're in labor, getting the baby's head to come down naturally, laboring down the head actually allows the muscles a chance to untighten themselves and loosen themselves up so that you can get the baby out normally. We do know that old school forceps deliveries, which they do less and less of now, those tend to carry a risk factor for pelvic floor disorders because probably they stretch the muscles suddenly and maybe break or damage some of the muscles. We do know that when pelvic floor muscles, the muscles around the vagina, get damaged during childbirth, those tend to carry the biggest risk for pelvic floor dysfunction. And in fact, some of our own research showed that if the sag in the pelvic floor muscles is too great, then the risk of pelvic organ prolapse repair is actually of it actually lasting is much lower. So damaged pelvic floor muscles is the worst possible risk factor for recurrence after treatment, and also probably for occurrence, because we understand the pelvic floor muscles themselves actually provide support to the vaginal tissues and help hold the tissues in place as well. So what you do to prevent pelvic organ prolapse, not sure that there's anything that's actionable that we know that is evidence-based and bulletproof, but I think good labor techniques, good practice for delivering your babies, making sure that you get your regular exams and follow-up, making sure that nothing goes wrong there. In terms of surveillance, those are probably the big ones.
Okay.
Yeah.
Thank you. How do life stages like pregnancy, postpartum recovery, and menopause change pelvic floor needs?
So pregnancy itself, we don't think has a major impact on the anatomy of the pelvic floor, just pregnancy by itself. In pregnancy, there are higher levels of progesterone and estrogen. Progesterone is a relaxant for smooth muscle and tendon and so forth. Usually that once the pregnancy is delivered and the progesterone levels go back to normal, that tends to not be an issue. Pushing a baby out through the vaginal tissues, we talked about earlier, laboring the head down, if you will, to get the muscles to relax or to untighten over time is probably decreases the risk factor for pelvic floor dysfunction, maybe. Do not, if at all possible, not using forceps or vacuum deliveries will actually help. Please bear in mind that in the labor and delivery suite, the doctor, the obstetrician is going to do what's right for that baby. So if getting the baby out is urgent and immediately required, and forceps are the only way to do it, and there's no other way, that's what they need to do. That's not a decision for that labor and delivery suite, similarly with vacuums and other mechanisms. But we're talking about the risk factors, forceps, anything that would damage the pelvic floor. That's childbirth part. Postpartum. Well, the postpartum state usually is a state where estrogen levels are low because you just delivered a big placenta and lots of estrogen is being normalized. If you're breastfeeding, you're probably not going to have periods right away. Doesn't mean you can't get pregnant, but your periods won't come right away. And in breastfeeding, the estrogen levels are lower. When the estrogen levels are lower, it looks like you're in menopause from the vaginal point of view, and sometimes the vagina can behave in ways that mimic menopause. That by itself will not cause a problem. So I think once you get through the childbirth and delivery piece and you get through postpartum, life is going to continue on. If you're having a lot of lifting, straining, parachute jumping and so forth, whatever the injury to the pelvic floor that can happen as a result of that will happen. The next phase, I think, would be the perimenopause period when the estrogen levels start falling. We know, and we're actually writing a book on the subject with my colleague, Dr. Vince Callahan, on menopause, what's menopause got to do with it, so look for that. That's coming pretty soon. But what menopause will do is it will change the hormonal milieu in the system. It will change your systemic estrogen levels, progesterone levels, and testosterone levels. That alters collagen. It alters the strength of the tissues. It alters the suppleness of the vagina, and you can actually start feeling pelvic floor dysfunction type symptoms like pressure and pushing, as well as the recurrent UTIs and pain within the course and things like that. So menopause will have an impact on the vaginal and urinary system as well. That can be remedied by replacing the estrogen and possibly the testosterone. That's happening around perimenopause. So that's worth a visit to your practitioner to look at those numbers as well, to make sure that you don't need anything in terms of hormone replacement. So that's the perimenopause. Usually at the time around the 50s or thereabouts, age 50, there's been enough of the insult which happened at childbirth and a lot of the activities that kind of stress the pelvic floor so that the prolapse begins to show up right in that 40, 45, 55, 60 type time frame. So that's what we're looking at. At that point, early prolapse that may not be judged to be symptomatic. If it's not symptomatic, you don't have to do anything about it. If it's symptomatic and you really don't feel like you want to do surgery, there are options including physical therapy, and pessaries are also devices or inserts that can go in the vagina that can help prevent or ameliorate the symptoms of prolapse in the short term. They're not long-term devices necessarily, but they can help in the short term if you're feeling like you don't want to do surgery. Surgery is not required, it's not mandatory, it's not necessary unless there's meets certain criteria. But if you want, there are non-invasive methods.
Oh, wow. So there is the temporary option. You mentioned some things that can be inserted.
Sure.
Other than having an actual surgery.
Sure. There are devices and they were invented hundreds of years ago. They're called pessaries. They've been refined over the years. They're actually now rubber or latex-free inserts that'll go inside the vagina and expand. And when they expand, they actually can hold the vagina in place and prevent the bulging. And many times will make the symptoms better. The urinary incontinence, the frequency, urgency, the bulging symptoms can sometimes get better in the short term if you use pessaries.
Oh, wow.
Most women don't want to continue long term with pessaries because they have that stigma of being, quote, old lady devices, and if you're having intercourse, they sometimes can get in the way of intercourse, so you have to manage them around intercourse. But for many women who want that, they can actually do that. Other women will choose to have physical therapy to help strengthen the pelvic floor muscles, and by strengthening the muscles, they can tighten the pelvic opening to hold the vagina back in place and kind of make the prolapse feel like it's better.
Oh, wow. Wow. That's good to know.
Yeah.
Great information.
Sure,
Thank you.
You're welcome.
So if a woman is already experiencing pelvic floor issues, what treatment options are available for her today? Available, I meant to say.
Sure, absolutely. So let's talk about the major ones that women come in with. The big one is pelvic organ prolapse, in which the vaginal tissues, that vagina, which was an innie to start with, held in place, is now bulging all the way out. You can actually look down, you can see it. It's a nuisance. She does not want it to be like that. It's cramping her lifestyle. She has trouble urinating. She has trouble with bowel movement. She has urinary frequency, urgency, and some leakage. She wants it fixed. She does not want a pessary, and she tried physical therapy. It ain't working. The technique really involves taking the vagina and pulling it back up into place. And that's a surgical procedure. The definitive way that we know of to do it right now is to go through the abdomen. These days we go minimally invasive, laparoscopic or robotic, to find the backside of the vagina that's falling out. And where it's falling out, you take it and you pull it back into place and hold it up. So the holding up part of the method involves either tacking the vagina down to the ligaments that stretched in the first place, that'll hold the vagina and pull it back into place. That works well many times, but not all the time. The other method involves using a graft to actually attach to the front and back of the vagina. And when you pull up on the tail of that graft, you can actually pull the vagina back into place. And a competent, capable, skilled surgeon can tack the tail of that graft down to the inside of a ligament on the inside of the sacrum, which is the inside of the sacrum, the spine, and tack it down to hold the vagina in place. Those grafts themselves can be made of synthetic material or mesh, or sometimes they can be your own tissue, which is a technique that we've used ourselves quite successfully, using your own tissue. We find that many of our patients do not want to have synthetic mesh for one reason or another. Even though the mesh is considered to be standard of care by most societies and providers, some women will say, I don't want that, and in that case we can offer to use their own tissues to hold the vagina into place. And those procedures tend to be really durable. A lot of women Durable as in last long time. A lot of women will come and say, well, I've heard that you have to repeat that procedure every 3 to 5 years. And in modern, that usually applied to older techniques for fixing prolapse, usually done through the vagina. But didn't really fix the real problem. Those tended to be repeated often, and they ended up over time closing off the vagina. Usually, not all the time. But the newer techniques, the more modern techniques that are done laparoscopically and robotically tend to last for longer periods of time. There was also a phase in the past, recent past, where people were using synthetic grafts placed through the vagina to try and hold the vagina up and hold it into place. Those techniques, transvaginal mesh techniques, had unusually high share of complications and issues, and are not used as often. There were FDA warnings placed on the use of transvaginal mesh for prolapse repair, and those warnings have been heeded, and so the use of transvaginal mesh placed through the vagina for prolapse repair, that incident of that usage is decreased. It's not discouraged. The use of transvaginal mesh for prolapse repair is discouraged. However, you can still use mesh to address urinary incontinence, which is the next thing we'll talk about.
Wow.
So urinary incontinence, that's the second type of issue that women experience. It's probably more common than the prolapse issue. Leaking through the urethra, bladder contents, urine, is quite a distressing set of situations for women, and there's ways that you can leak related to an overactive bladder, which is usually a medical treatment. Sometimes you can leak because the spigot or the urethra that holds the urine in is on the weak side, and with coughing, laughing, sneezing, straining, position changes, there can be leakage because of that. Those tend to be fixed these days mostly with a procedure called a sling procedure, which is a little necklace that's placed around the urethra to hold it in place, and it actually acts to prevent leakage with straining type maneuvers. Those also work very well. We've also developed techniques to do the sling without using synthetic mesh, using your own tissue, and those have also been shown to be very effective. So those are surgical options for addressing stress incontinence, which is one type of leakage that can occur. The other type of leakage is leakage related to an urge. So you're sitting here, you feel a strong urge to urinate, you get up to go to the bathroom and you leak before you get there. That's usually urge incontinence. It goes along with gushes of urine, whole dumping of whole amounts of urine, and that's usually a medical or pacemaker type treatment which exists for that. There can also be Botox, believe it or not, injected into the bladder to help urge incontinence. Okay. But the other type of incontinence, the so-called stress incontinence, is usually addressed sometimes by pessaries as well. They can help. They don't work as well over the long term, but the definitive treatment is a procedure called a sling procedure, which is done surgically and can be very effective in correcting stress incontinence. As with all surgical interventions, there are risks, benefits, and side effects and alternatives that have to be pondered seriously. Nothing is 100%, but these techniques that I described can be very effective with a low side effect or risk profile associated with them.
So this is two different types of procedures or issues then,
right,
other than the pelvic
prolapse. Right. So the prolapse is actually the outie, the bulging outward. That's
so you mentioned you can see it?
Yes, sometimes some women will have prolapse that they can actually see. So the labia, you normally look at the skin, and it's normally your skin color. Mm-hmm. And when you look and you see something a little lighter colored, a little pinker, maybe redder, coming out from between the labia are separated, it'll bulge out. Yes. Mm-hmm. I'm sorry, don't mean to gross anybody out, Latanya, but it happens sometimes. So if you see that, don't freak out. Your bladder is not going to run off and leave you. It will not do that. Things will not fall out and go away. You will not die from it. It makes sense to kind of calmly find a urogynecologist, pelvic surgeon, your female urologist who can help you diagnose the problem and then offer you a treatment plan that can work for you.
Wow.
So it's fixable.
Wow, I am blown away by all of this. I didn't know that this was so common amongst women. This is amazing what you do. Well, I can't wait to get that book. To learn more.
So wow. we actually also wrote a book on prolapse repair that's on the shelves right now. You can get it. It's prolapse repair, but that addresses the bulging function. The other big issue, and I think we have to come back, Latanya, and talk about that, is the whole business of menopause and what happens to women around the time of the change. and the whole set of systems that get affected by changing estrogen and testosterone levels in women. Bones, skin, vagina, bladder, bowels, okay? Brain function, cardiovascular function, muscular strength, libido, energy levels, all of those things, every single body system is impacted by actual estrogen. And so in menopause, when estrogen levels start changing, all of those symptoms are at risk. And I think there's a piece of urgency now around helping women to understand, once you get to perimenopause, if you can get the estrogen replaced within the first 10 years of perimenopause, you can decrease colon cancer risk, cardiovascular risk, dementia risk. You can keep your bones strong.
Wow.
And you can just keep yourself in good condition as a general matter. So we need to come back and talk about that.
Most definitely. My audience, yes, we are mature ladies. We are in perimenopause and menopause, and definitely I cannot wait to come back for the menopause segment, as well as I'll talk about those hormone replacement pellets that we got to get our hormones together, ladies. You know, let's talk about mesh complications. Definitely anyone dealing with this issue definitely want to know what the complications can be.
So one of the things that we've done in our practice is we also specialize in addressing surgical complications. So among the complications that can happen when you attempt to correct pelvic organ prolapse or urinary incontinence is you could have complications. No surgical procedure is 100% anything. So the complications of these surgeries for prolapse repair first can include, you didn't leak urine before, you're peeing better now after the prolapse repair, but now you're leaking. Usually we address that by testing the bladder with the prolapse and simulated repair before we try to do the repair. If that test says that you're not going to leak, we tend not to do anything about leakage, because leakage can have leakage repair can have side effects. So if you have prolapse repair and you have leakage, that's something that needs to come back and be addressed. If you have prolapse repair with the abdominal procedure that we described, you can actually have mesh complications, including mesh erosions. Mesh can erode into the vagina, into the bladder, into the bowels. All of those would need to be diagnosed. They would be presented by urinary frequency, for example, blood in the urine. They're extremely rare, to be sure, but blood in the urine, urinary frequency, pain with intercourse, vaginal bleeding, difficulty with bowel movements. If you have any of those symptoms after a mesh repair, it makes sense to come and have that tested and checked out and see about what it takes to get that addressed. In terms of mesh complications related to urinary incontinence treatment, slings can be too tight. So that means after the sling, you're having difficulty emptying your bladder, and usually that shows up like, oh, now I can't pee, now I have to pee every 5 minutes, then I can't pee, now I pee every 5 minutes. Those things can require a loosening of the sling or sometimes removal of the mesh if it's indicated as well. So mesh complications are real, they're extremely rare, but when they do occur, it makes sense to come find a surgeon who specializes in them. There aren't very many of us that do it, but those that do it very well, those are the kind of surgeons that you need to go visit with to have them evaluate you. We've done hundreds, maybe thousands of mesh removals and redo of prolapse and incontinence surgery with non-mesh techniques that we developed. So we've gotten really good over the years at addressing mesh complications and getting women to get their lives back. Transvaginal mesh repairs had their share of complications that they've created over the years. We've done a lot of those removals as well. They tend to be less and less now that most of the new surgeries for fixing prolapse tend not to use transvaginal mesh, but we've also addressed those as well. So if you had a mesh surgery and you feel like you had a complication, something's not right, it makes sense to go check with a urogynecologist, pelvic reconstructive surgeon, female urologist, who can actually help you get through some of those issues as well and get them back. Mesh complications are usually very difficult to fix, extremely difficult to repair, but they're worth addressing. And in the right surgical setting, at the right kind of surgeon, usually we can help make those women be better as well.
Wow. Well, thank you.
You're very welcome.
Letting us know that. That's good information to know. So, Dr. Hoyte, the big question is, where can people find you, and are you seeing patients? Where are you located? And how can people contact you? Do you have a website?
Sure. That's a really good question, and thank you for asking that. We are the Pelvic Floor Institute. We have offices in Bartow, Clearwater, and Sarasota, soon to be an office in Tampa, Florida as well. We can be found on our website. It's www.mypfi.org. M for Mary, Y for yesterday, P for Peter, F for Frank, I for insect.org, mypfi.org. You can find us there. You can also find me on my website, my full name, lennoxhoyte.com, but preferably the Pelvic Floor Institute. Our phone number to reach us is 863-354-1900, and we'll be happy to have you come in for an appointment. Come in and see us. We'd love to see you. Thank you so much.
Well, thank you so much, Dr. Hoyte, for that information. And guys, I will have all the information linked in the description box, so don't forget to check it out. This is some serious stuff we're talking about. So I just want to say thank you so much, Dr. Hoyte, for allowing me the presence just to be able to interview you. And thank you for coming on the Living Irving show today and educating us on all of these issues. And guys, make sure to seek professional help if you are experiencing any of these symptoms. And of course, Dr. Hoyte is available. I look forward to having you back again to come on here and talk about some more issues surrounding menopause and so many other things, great things that you do. So thank you again. Is there anything else you'd like to say before we close?
You're very welcome, Tanya. Thank you so much. You don't have to live with pelvic floor disorders. You don't have to live with urinary incontinence. You don't have to live with leakage. You don't have to live with pain. And you certainly don't have to live with prolapse or difficulty with your bowels or your bladder. Get it checked out. Get it treated. There's a really, really good chance that you can be helped with non-surgical, pre-surgical, medical, or surgical techniques. But please do take a minute and get yourself evaluated so you can get your life back. Yes. Thank you so much.
Thank you, guys. Thank you so much for joining today. Leave me a comment below if you have any questions for Dr. Hoyte. Please leave them in the comments. We will get them to him and get them answered for you. And again, love you guys. Thank you for joining, and I will see you in another video. Bye.
Bye.